Hi, everyone. I think we're going to go ahead and get started. I know some people are still logging on. Welcome. My name is Julie Dudkowski, and I'm one of Skyland Trail's National Referral Relations Coordinators or representatives here at Skyland Trail. There's 5 of us nationwide. We are so glad that you can join us today. Before we get started, I'd like to just tell you a little bit about Skyland Trail in case some of you are not familiar with us. We are a nationally based mental health organization, and we specialize in treating adults who have a primary mental health diagnosis through our residential and day treatment programs. Our adult program has 4 evidence-based tracks: CBT, intensive DBT, first episode psychosis and cognition, and social integration. We can also offer dual diagnosis as a co-area of focus for people who are in recovery from a substance use disorder. Our adolescent program treats teens ages 14 to 17, who have a primary mood and anxiety disorder. We can also work with teens who have secondary substance use disorders if it's mild to moderate. And we're now also working with teens who have secondary PTSD. Our 2 evidence-based tracks at the adolescent program are CBT and DBT. We do work with a lot of private insurance now. We're in network, and we also are in network with TRICARE East. And we, as a nonprofit, offer need-based financial assistance towards out-of-pocket costs to help families be able to afford costs. Both of our adult and residential programs can admit clients to either residential or day treatment, depending on the level of care that's most clinically appropriate. And you can find more information about our services on our website at skylandtrail.org. Thanks so much. And it's now my pleasure to turn it over to Molly Mercer-Dedman, our Education Outreach Director, who is going to introduce today's speaker. Thank you.
Thanks, Julie. So I'm going to go over some housekeeping before we get started. You must attend the duration of the webinar today in order to earn CE credits. After the event, you'll receive a personalized link to your attendee dashboard, which is hosted on the CEGO website. So on the dashboard, you'll be able to complete your evaluation form immediately and download your CE certificate. It's a Zoom webinar, so please use the Q&A for questions throughout the presentation. I know that Caitlin and Dr. Rothbaum will leave some time at the end to get to those. Also note that Zoom allows participants to enable closed captioning on their Zoom screens, so be sure to enable that feature if you'd like to. The slides will not be distributed, but a recording of the video will be available on your CEGO dashboard and Skyland's website following the event next week. All right, so now it's my pleasure to introduce Caitlin Connolly and Dr. Alex Rothbaum. Caitlin is a licensed clinical social worker and a certified prolonged exposure therapist. She is currently the Director of Clinical Services at the Skyland Trail Adolescent Campus. She is experienced in community mental health, corrections-based mental health, trauma-focused care, treatment for co-occurring disorders, and mental health in various education settings. Dr. Rothbaum is a researcher, educator, and clinician with a focus on translational approaches to better understand and develop interventions for trauma, PTSD, health disparities, and social determinants of health. Dr. Rothbaum is Director of Research and Outcomes at Skyland Trail and an adjunct assistant professor at Emory University. He received his PhD in clinical psychology and Master of Public Health and Population Health Research from Case Western Reserve University. Dr. Rothbaum has clinical experience in hospital, intensive, and outpatient settings, providing evidence-based psychotherapy, and has been trained as a prolonged exposure consultant. Caitlin and Dr. Rothbaum, I'll pass it over to you.
Awesome. Thank you so much, Molly. And thank you everyone for being here today. We are extremely excited to be able to bring this presentation to you all. And thank you for taking time out of your afternoon. It is a very important topic. It's a very special topic to both Dr. Rothbaum and myself. And we hope that you all can gain some really great information and find some ways to adapt prolonged exposure into your treatment, but also just to have some more awareness about PTSD. So quickly to kind of go over the objectives of what we'll do here today, we want to really focus on how to help understand the rationale for exposure-based therapy, specifically to treat PTSD. There's a lot of misinformation, there's a lot of misunderstanding about exposure-based therapy, and so we will spend some time going over the rationale for all of that, specifically related to working with PTSD diagnoses. We'll also talk specifically about how to adapt PE in the adolescent residential population. Having the opportunity to work with Alex at Skyland Trail, we've been able to do some really great work of how to specifically bring prolonged exposure therapy into the residential setting for adolescent patients. And we're really excited to share some of the information of how we've adapted that here at our program and how others might be able to take some of those ideas and adapt it into other settings as well. We also want to talk about case conceptualization of adolescents with comorbid PTSD. So how do we pick apart and understand the ideal PTSD candidate for prolonged exposure? How do we address other areas of their mental health, including depression, anxiety, some possible blossoming personality disorders? And then we'll talk a little bit about evidence-based treatment and assessments for the adolescent population with the comorbid PTSD.
Awesome. Thank you so much, Julie, Molly, and Caitlin. Caitlin is the brains behind the implementation, and she'll be telling you all about that. And it's a really cool setting to do implementation work and some really cool adaptations. I'm going to start by doing an overview of PTSD and trauma, just so that we're all on the same page as we think about these and think about how we do it in such an environment. So I think really important is trauma exposure is really common. Most of us on this call, most of the people we know have or will experience a trauma that could potentially lead to PTSD. And so, while PTSD is a significant minority of people who experience trauma, a lot of people experience trauma. And this will be important as we kind of think about treatment and treatment implementation. And I think important here, and it's important for a lot of reasons, is to really define what we mean by trauma. And so trauma has kind of taken on a life of its own in the community. And on the one hand, this is really great because it's, I think, helping break the stigma and make people know that there are impacts of trauma. And I think for a while, also PTSD had this connotation that it's just a disease of war. And so I think on the one hand, it's really good, right? Because it's building awareness, breaking down stigma. On the other hand, it's kind of muddied the waters a little bit. And so when we think about trauma, we use the DSM criterion A definition of trauma. And so that's exposure to actual or threatened death and serious injury or sexual violence in one or more of the following ways. So experiencing, witnessing, learning that the event occurred to a close family member or friend, or experiencing a repeated or extreme exposure to aversive details of the event. Keep in mind that with each revision of the DSM, this has changed a little bit. So, stuff with DSM-4 is using the DSM-4 definition. This is DSM-5, but it's all kind of the same feeling. And so we're, this is what we are talking about when we're talking about trauma. This also, so I've done a lot of work in level 1 trauma centers across the country. And, I think an important distinction here is also the difference between a psychological versus medical trauma. There is certainly overlap. But it's important to distinguish. So trauma centers and surgical trauma, right? When you go to those centers, it's blunt or penetrating injury. And that is a little bit different. And so blunt or penetrating injury can be about many different types of events, right? Whether it's a ground level fall, a car crash, or a motor vehicle, or a gunshot wound. When we think of psychological trauma, this is criterion A. This is the stress resulting from a criterion A traumatic event. And, examples where there is differentiation is, so sexual assault, for example, always meets criterion A for trauma. It wouldn't necessarily end up in a trauma center unless there's a blunt or penetrating injury. The opposite is ground level falls. So this is someone who trips over something on the floor and falls and breaks their hip or skins a knee, or is drunk and falls over and gets taken to the emergency room. This is a lot of times wouldn't meet for a criterion A event, but is a medical trauma. We also want to be clear that, yes, trauma exposure is common, but PTSD is not the only outcome. I think there's a lot of thoughts out there that like, if you have trauma and you develop problems, it's going to be PTSD. This is adolescent data that we're showing from the Great Smoky Mountain study. And this is showing that you can have a lot of different potential mental health sequelae after trauma exposure. And this is DSM-4. So at that time, remember, PTSD was still an anxiety disorder. And so that is the triangles there. But depression, there's substance use, and we'll talk about some of those a little bit more, but keeping in mind that PTSD is not the only outcome. So PTSD in itself. So PTSD, an event has to happen. You can have every risk factor known and unknown, and you're not going to get PTSD unless you have a criterion A trauma. And the symptoms must be present for at least 30 days. So at less than 30 days, it's acute stress disorder. In 1 to 3 months, it's acute PTSD. And at more than 3 months, it's chronic PTSD. Once it's chronic, we generally say you need treatment. It's not going to get better on its own. And there's a lot of increased risk when someone has PTSD for physical health, from substance abuse, for other mental health disorders. And when we look at how it kind of plays out, it's a very prevalent psychiatric disorder. And less than 10% of people who experience trauma will develop PTSD. This changes depending on your subpopulation. So it is higher in those who experience violent traumas. It's twice as common in women. It's higher in combat veterans. It's higher for those familiar with the Grady Trauma Project, which is the largest epidemiological study of civilian trauma. It's higher in populations that are historically underserved and experience chronic traumatization. But what remains is it is still not everyone who experiences trauma, and it's still not the majority. PTSD has only been around as a diagnosis since 1980. And it was this Horowitz paper cited here that really kind of put it together, in Vietnam veterans, examining the signs and symptoms, grouping these behaviors and cognitions together, that we were kind of seeing avoidance, numbing, intrusion. And, there's some depression, there's some anxiety, and it was kind of this nebulous but distinct thing that has evolved with each version of the DSM and as our understanding increase. That being said, PTSD is not a new human experience, right? That's just what we're labeling it now. So this is a paper looking at the idea of PTSD in Shakespeare, and showing that, if you're taking some of I believe this is an excerpt from Midsummer Night's Dream, right? That you're seeing a lot of the re-experiencing, avoidance, increased arousal that we see in PTSD. It just, we didn't call it that. In World War I and World War II, this was a lot of times what we called shell shock. So the experience as part of the human existence is not new. How we label it is relatively new in terms of history. So this is PTSD in DSM-5. So you have these different criteria. You have the exposure to a traumatic event. We have the different symptoms, which we'll get into in a second. The duration, like most psychiatric illness, right, that it causes distress and impairment, and that it's not related to a substance or another medical condition. So when we look at the clusters of symptoms that are present in PTSD, we have re-experiencing. So these are things like nightmares, flashbacks, intrusive thoughts, and this is, things that just kind of pop into your mind and you can't push it out. And those are different than reminders. So then we have avoidance. So this is avoiding of thoughts, feelings, memories, people, places that remind them of the trauma. So when we talk with patients about reminders, and they say, a lot of times he's like, when you're walking in the grocery store, when you're walking in Walmart, when you're walking in Target, when you're walking through school, is it just coming to you? And then they'll give me an example. And I say, okay, so there's something that reminds you of that in that situation. And right, we have to kind of work with people, because we as clinicians are used to kind of parsing it out, but that's not what people are doing in their normal life, and that's normal, but it's up to us to help parse it out. We have the changes in mood and thinking. So this is, when we see the overlap in depression, this is the world isn't safe. Everyone is dangerous. Everyone can't be trusted. Everyone's out for themselves. A lot of guilt and shame, whether or not someone else is involved, right? So we see this with people who have been sexually assaulted. There's a lot of guilt and shame around that. But then if we have people who are involved in violent crime with someone else, and someone else was injured more or died, right, there's a lot of guilt and shame there too. So it can be different ways that guilt and shame rear its head. increased arousal and activity, hypervigilance. This has really taken on a new kind of how it manifests in the last couple of years, because we have all these internet connected cameras, right? So before it used to be like you're checking around your car, you're checking around you before you're leaving your house, you're having your back against the wall when you're eating in a restaurant. Now it's also like I got cameras everywhere, right? And I'm checking the cameras while I'm in bed. I have them notifying me. I have a tracker on my kid, right? So those can all still be hypervigilance, and we should be mindful of how technology affects that. Exaggerated startle, so the car backfires, I feel like there's a gunshot. Sleep disturbance. Again, this is where we can have some overlap with other things. You want to do some differential diagnosis. Anger and reckless behavior. The key here is that not everyone's PTSD looks the same. And so even if they experience the same event at the same time together and they both develop PTSD, these people are likely going to have different manifestations and different symptoms that are present. So this is a great paper by Isaac Gallagher-Levy and Richard Bryant showing that in DSM-5, there are over 600,000 different combinations of symptoms to lead to a diagnosis of PTSD. So keeping in mind that everyone looks a little different and it's a pretty heterogeneous disorder.
All right, awesome. So Alex has given us a really great overview of PTSD and trauma. And so I'm going to spend a little bit of time talking specifically about what trauma, criterion A trauma, looks like in teens and children. As Alex mentioned, there are a number of different ways that criterion A trauma can show up. There's a number of different ways in which trauma can be expressed by an individual. And so we're going to talk a lot generalized, but we'll also provide some good examples of kind of what we're seeing in the work we do as well. But as we talk about what are children and teens experiencing the most when we talk about criterion A trauma in this population, we see primarily sexual or physical abuse, and that could be at the hands of parents, legal guardians, siblings, someone in their immediate social community, and that can also be strangers as well. We talk a lot about how they can witness or experience a violent crime. So again, as we talk about the vulnerability of children, what is that like for them to witness someone being harmed physically, whether that's the domestic violence in the home, whether that's some sort of gun violence in the community, whatever that may be. In addition, environmental disasters. So we talk about things like these fires that happen on the West Coast or in Hawaii, et cetera. How are these impacting children and teens differently than maybe adults who maybe have more understanding or maybe even experience with some of these situations? And unfortunately, more and more we hear in the news things about school shootings that is impacting young people extremely, extremely to the core. Car crashes, house fires, again, other things that these young people might be exposed to that might lead them to experience a criterion A trauma. Again, the experience of whether or not their life was in risk and whether or not they feared for their life. Suicide of a friend or a loved one can also be considered a common criterion A trauma for children and teens due to the fact that their safety may have been jeopardized in one way or another. Again, we'll talk more about this, but the context is really important here. So one of the things that makes doing trauma work with children and teens especially different is the fact that Child Protective Services may be involved and oftentimes can be involved. And so I thought it would be really helpful to kind of break down what are we seeing nationally based on Child Protective Services reports, and how does that correlate with some of the abuse reports that we're having. Again, these are just the things that are reported, but we see that 65% of cases are related to neglect, 18% of reported cases are related to physical abuse, 10% of cases are related to sexual abuse, 7% related to psychological abuse. So again, those are really large numbers. Those are the numbers that, again, are proven cases. These are not necessarily the cases that were screened out. These are not necessarily things that were not reported. So this is a huge issue in our country, as we can see. And so it makes this conversation even more important. Another piece of information that I think is really important is that last little arrow there that talks about 40 to 60% of all reported cases involve some sort of family violence. So this child not only witnessing family violence, but also being subjected to abuse in some sort of form or fashion. So next slide, Alex. All right, and so Alex did, again, a great job of really painting a picture of what PTSD looks like, criterion A trauma. And again, as we talk about access to social media and information, I thought it was really important to kind of break down what some of these symptoms might actually look like, or presentation that trauma may look like in different age groups of minors. So again, as we talk about development, as we talk about maturity, there are going to be different ways in which young people express PTSD symptoms differently than possibly adults. So we can look at first at the preschool age children. This is the group of children aged 1 to 5. And again, 1 to 5, that is very young. We might ask questions of how can someone that young develop PTSD? Again, situations are going to arise where someone's symptoms can be either prolonged based on ongoing trauma and or again, based on a number of different factors that they're experiencing. So what might this look like for a child this small? So there might be things related to temper tantrums, irritability, sadness. A lot of times people can reference trauma based on regressive types of behavior. So this might be things like wetting the bed when they are potty trained, sucking their thumb. And we also see that PTSD symptoms can resonate in young people as physical symptoms, things like stomach aches, their belly hurts, etc. Again, these are things that may not be explained by other diagnoses and or experiences that they're having. And that's not to say that adults don't experience these same things, but as we know, a young person who may be 1 to 5, they may not be able to vocalize what happened. They may not understand what they've experienced. And so as we start to gather data, it can be really helpful to piece these puzzle pieces together. School-age children, you can see a lot of the similar things, but a lot of it's now going to be blossoming a little bit more into more emotional outbursts, things like anger and fear, sadness. You might have some of that irritability. We know that middle school is a hard time for kids as it is. So now let's add in trauma. How is that going to come out in even bigger ways and more even challenging ways? So that's where we might start seeing some more of this hopelessness and some of these maladaptive behaviors that in our work we're seeing at younger and younger ages. Maladaptive behaviors I'm referring to are suicidal ideation, self-harm, things of those nature. So again, Alex talked pretty extensively about hypervigilance and hyperarousal. So again, these are things that these young people are starting to experience and expressing more. How are they, sitting in the classroom? Do they have to sit at the back of the classroom because they need to be able to have their back to the wall, be able to face the door? They don't want anyone behind them because they don't know what's going to happen. And then we notice a lot of increase in their negative self-talk. We can see that this is where a lot of that shame, that guilt can really start to penetrate young people as, again, they're developing. How is this trauma impacting their sense of self, their view on themselves? In addition to things like reliving the trauma, nightmares, and flashbacks. Something that is important to keep in mind is that there might be some reenactment of the trauma in play, and that could look different ways, whether it's with dolls, whether, we know a lot of young people like to play their video games. So it's important to kind of keep those things in mind as we're painting a picture if trauma is really what's going on here. Again, physical symptoms. And then teenagers, as we talk about, a lot of what we'll share today is based on the adolescent population here at the Skyland Trail campus. So our kiddos fall within this category. So ages 12 to 18, and they do experience trauma symptoms most similar to those of adults. What we do start to see more of, though, is some of these risky and impulsive behaviors. So what does that look like? So this might be some experimentation with drug use. This might be some experimentation with sexual behaviors, sneaking out, things of that nature. And then we might also see a lot of difficulty in their interpersonal relationships. How are they communicating with others? They may be shutting down more. They may not have a strong ability to trust other people. And then again, we see more and more of that development of destructive self-worth or lack of self-worth based on their own shame and guilt. And so we'll talk a little bit more about these presentations as well when we do some case studies and share some information of things we've seen specifically. But that's just kind of an overview of PTSD in children and teens. So next step.
Awesome. So across age groups, one of the things that unites PTSD is it is characterized by avoidance. PTSD is a fear-based disorder. So it is a disorder where there is fear to an objectively a stimulus that is objectively safe but is causing fear but is perceived to have threat. This includes memories, right? So it means that your body's feeling like if you have these memories, we're going back to it again, we're in danger again. We need to prepare. So all of these things are avoiding, and you never have the opportunity to learn that they're safe and that they're not dangerous, and it interrupts the natural recovery process. And so when we look at this, so this is a prospective study of those who've been sexually assaulted. Is one of the first prospective studies of PTSD. And what we see is at week 1, 94% of people have PTSD symptoms, right? It is natural part of the human experience to have PTSD-like symptoms. I really want us to make that message clear. It's after it doesn't go away that it becomes pathological and in need of treatment. And here's another graph from that same study. So we can see that the people who don't end up getting PTSD in orange start high and go down as the weeks continue up to 3 months. The people who get PTSD start high and stay high, and we see that they diverge. So we can really think of this as, the brain is still thinking that everything is unsafe, and we'll talk about what that looks like conceptually in a little bit. This is a later study showing that there are different trajectories even beyond that. But again, people who don't get PTSD, it's natural to have symptoms and they decrease as time goes on. In PTSD, comorbidity is the rule rather than the exception. So this is early data from PTSD that still holds, showing that both in men and women, having other psychiatric diagnoses is very common. This can be depression, this can be anxiety disorders, this can be substance use, and so on. This is data in adolescents and looking at PTSD in childhood, and you can see that, with the increase in trauma symptoms, there's an increase in other psychiatric illnesses. Here is data from the National Comorbidity Survey adolescent version that Katie McLaughlin, who's an expert in child PTSD, is on this paper. Again, showing that even when we look at substance use rate, then increase in trauma exposure also has a weight in the dose-response relationship to substance use comorbidity. And then the Great Smoky Mountain study, they did a subset where they looked at about 1,400 kids starting age 9 and 11 and 13, and then followed through 16. 2/3 reported at least one traumatic event in the study time, right? So again, trauma is very common, even if you haven't lived a long life yet. What they found is very few with one event developed PTSD, and the highest rates of PTSD were those who experienced violent or sexual trauma. So, yes, we certainly see that PTSD is more common with violent traumas, even in adults. And I would say, yes, there's probably a dose-response relationship that we've seen with adults and PTSD. There's not as much results back in adolescents. So don't say, oh, they've only had one event, they're not going to get PTSD. They can still get PTSD from one event. But there is data to suggest that there is more trauma, more likelihood of getting PTSD. And one of the known risk factors for PTSD from trauma is having PTSD from a previous trauma. So you can get PTSD again, even after you've been treated. When in doubt, back into the symptoms. So it can get really messy with comorbidity. It can get really messy when you're with a kid or a teen who's also not good at talking about their feelings and figure out what feelings are. And, we're going to talk about these treatments and kind of think about how would the treatment work and what would we be targeting? And are these targets there for the treatment? Or is this a different treatment, right? It doesn't mean that they're not having impairment, but if they don't need exposure-based therapies, or what would you do in vivo exposure to, and we'll talk about that is in a moment, then maybe it's a different treatment. It's more CBT or DBT. So that is one way that we've done it here and other places that I've been, right? If it gets messy, back up, map the symptoms onto the treatment.
All right. So as we've mentioned, it depends on the person, it depends on the situation. in which someone might develop PTSD. You know, Alex and I can both experience the same trauma, and one of us may develop PTSD and one of us may not. It's really important to identify specific risk factors or maybe some presenting historical background that may be helpful in establishing what is really going on with the patient. So we wanted to break down what are some of these risk factors that someone might be experiencing that contribute to them having a PTSD diagnosis. And then that's going to help formulate the treatment plan, right? So severity of the event is always something that's going to be taken into consideration. So when an adolescent or young person is experiencing some sort of trauma, if their loved one or someone close to them is involved in the trauma, they're more likely to develop PTSD. Some sort of police involvement, separation from a caregiver. So was someone arrested? Did someone die? Did CPS get involved and they had to be taken to foster care? This may increase the likelihood of a PTSD development. Proximity to the event. So again, as we talk about hearing something traumatic versus seeing something traumatic, that is going to be a big indicator of whether or not someone is likely to develop PTSD. Versus not developing PTSD. So this might be something along the lines of someone who was in school the day a school shooting happens versus knowing that they only missed school that day because they had a doctor's appointment, right? How might those impact those young people differently, and how might they be likely or not likely to develop PTSD? Caregivers' reaction. This is something we're going to talk about a lot in our presentation today, just family involvement in general, but the way that our team, parents or caregivers respond to how they disclose trauma or how they respond to them witnessing this child's trauma, whatever that may be, is going to be an indicator of how this child develops, whether or not this child develops PTSD as well. I think that there's a lot of cultural components, there's a lot of parenting components, behavioral responses. There's so many different factors that lead to why parents may respond in a certain way. However, we do know that if a child is given more support and there's more communication, open discussions, etc., this child may be at a greater risk of not developing PTSD versus developing it. Prior history of trauma. So again, as Alex mentioned, if someone has had trauma previously, they can develop PTSD again. And then when we talk about the family and community factors, this can be a risk factor, but we can also talk about how community and family can also be a protective factor. However, we do see that experiences of racism or discrimination coinciding with a traumatic incident can also increase someone's likelihood for developing PTSD expression. And with that being said, context matters. We know that nothing operates within a vacuum and that there's a lot of different contributing factors in which a young person may or may not develop PTSD. So when we talk about internal homeostatic context, what is this young person's ability to actually regulate, self-soothe? What are their internal biological factors that may be contributing to their development of PTSD? With the content of the trauma, what actually happened within the situation? Was this a situation of sexual abuse, or was this something of witnessing some sort of violence in the community? And then community factors as a whole. I know I'm going to steal your example, Alex, but Alex uses a really good example of how someone who is born and raised in an environment with gun violence, if they come in with a gunshot wound, again, he talks about the trauma, the medical trauma versus psychological trauma. How is that going to impact a young person based on his community engagement, based on what he's been exposed to in his systems versus someone who may not have been? That gunshot may develop into PTSD for some people, and for others it may not. So again, the community, what their environment is presenting to them is going to be a huge indicator of whether or not PTSD develops.
And we can think of that when we think of risk factors, right? In that all these contexts are also risk factors or protective factors. So we have like the psychological aspects of trauma and the environment and our predispositions. We have what's going on in their body, right? Is there a lot of inflammation going on? There's preliminary data showing that cycling hormones and the levels of those can influence symptom severity and learning processes. There are genetic risk factors. There are epigenetic risk factors. There are neighborhood level risk factors, right? When we look at deprivation and status of housing and what that looks like. And so all of these are kind of mishmash in this great graph from Ryan Haringa can really kind of show that it is messy, right? It's not a one size fits all. We can be like, check, 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 they're gonna get PTSD, or it is a lot of factors that are at play, and we don't have good predictive models at this point. So yes, it's frustrating, but we have good assessments, and that can help in terms of tertiary prevention. Most people don't receive treatment for PTSD, and if they do, it's on average 12 years. So in the adult world, we see a lot of people who are getting treated for trauma they experienced in childhood and adolescence. It's not like everyone's like, yep, this happened, it's 3 months, let's go, let's take this and get it fixed. It becomes such a part of people's lives that for a lot of people, they don't even realize it's not normal, right? Or that it can be helped. It's just like, this is my life, this is what happens. And then you kind of go through what common reactions to trauma, and like, wow, I've been experiencing my whole life. And it's a sad state of affairs, but hopefully people like you attending can help raise awareness and get people into treatment sooner, so that there's not as much suffering. So, a good part of thinking about PTSD and thinking about PTSD is the translational model of PTSD. So this is bench to bedside work, and it's really relevant here because it's really foundational to PTSD. PTSD, when we think about it from a research standpoint, is kind of cool, right? So it's one of the only mental health disorders where we know what the precipitant is. We know what causes it, so we can look at before and after. So if you remember Pavlov's dogs, right? They paired meat and a bell over and over again to the point that when they just rang the bell, then the dogs would salivate because they had associated the bell with eating. That is new learning. That is called conditioning. And so we can think of trauma along those lines, right? Trauma is conditioning. If you that is the new stimulus, what you're avoiding is the perceived threat, right? That's been paired with it, like the bell. And we can measure that across species. So fear is an emotion and a reaction that has been preserved across mammalian species. So we can look at things in mice and in non-human primates and in healthy humans that help us understand PTSD and help us understand the treatments and make the treatments better. So this is fear conditioning in a mouse. So you can see that they flash a light over and over again. The light objectively is not dangerous, but they flash a light over and over again with a foot shock, and they also pair it with a sound. And if you pair the light over and over again with the foot shock, eventually the rat has a fear response to the right or to the light, even if there's not a foot shock. We can measure that with fear potentiated startle. So this graph on the right from Tanya Ivanovich, the gray is noise alone. How much do we just startle to a startling noise? And then what is our response to the danger? So the foot shock, and then what's that difference? So how much more is our fear response than normal? We can do this in humans too. We're not shocking humans, but we can take humans and we can pair aversive stimuli. In this case, what he's wearing is a device that gives an air blast to his larynx, and people will learn to associate certain shapes or certain stimuli with an aversive air blast, and we can look at how that learning works. And so this maps on the PTSD. So PTSD has that trauma that precipitates it, that's criterion A. There's an aversive stimulus. So if you get someone in and they were in a car crash and they had perfume in the car, and they might avoid that perfume because their brain's like, this is a danger signal, right? It's been paired, it's been learned. And this is like Pavlovian fear conditioning, right? It's reductionistic, but it's certainly like it, and it allows us to study. So what factors change how well people learn fear or not? What factors affect how reactive people are when they learn fear? And what are the biological risk factors for fear learning that doesn't go away? And so again, we have a loud noise, we have the foot shock, and we have if we do it over again, it learns to fear the stimulus. This is like traumatization. So for anyone who's been to Cleveland, there's an intersection on the highway called Dead Man's Curve. This is Dead Man's Curve. And objectively, it's not the best intersection, but there's nothing inherently dangerous about it. If we get in a car crash at Dead Man's Curve and we develop PTSD, right, then every time we go through Dead Man's Curve, we might have increased heart rate, we might avoid doing it, right? That's the learned behavior. That is the light or the sound without the foot shock, and the car crash is the foot shock. And so remember that cognitive behavior therapy, no matter what form it is learning, right? And there are all these different types of learning that happen and that influence how our brain works, what our brain is associated with, and how we're trying to change that. So we're never erasing anything. We are having new learning that changes how we're interacting with the world. When we think about treating PTSD, there are guidelines, and there's this great review of the literature that's a guide to the guidelines. So taking all of the different guidelines that have been in existence, this is an update, and saying what are first-line treatments, what are secondary treatments. This is a great paper to have access to. And they focus on evidence-based treatments. So most people will not get an evidence-based treatment for PTSD if they go in for treatment, and we want to help change that. When we think about what makes a therapy evidence-based, there have been well-controlled studies and multiple of them that showed it to be effective. It was compared to no treatment or other treatments and shown to be effective or better. Patients were randomly assigned to treatment groups, and there were blinded assessments. And those outcomes were assessed with valid and reliable measures with people who weren't also their therapists. The integrity and the dose of the treatment is checked, and the results have been replicated in other studies. That's what we think about when we think about evidence-based treatments broadly in psychiatry. And then we have cognitive behavior therapy is one of the best frameworks for evidence-based treatment. So it's an orientation for evidence-based psychotherapy. And there are great books by the Becks and others, and Dave Tolan on intros to CBT. It's transdiagnostically effective. It targets unhelpful thought patterns and behaviors. And we have this CBT triangle on the side where we're looking at thoughts, behaviors, and emotions and how they interact with each other and how we can change those. And there are specific CBT protocols for each disorder. For a lot of times there's CBTI for insomnia, CBT for chronic pain, CBT for substance use. There's also the third wave. So DBT and ACT are examples of third wave treatment, third derivatives of CBT.
All right, so then we want to talk about how we're measuring progress. How do we identify when someone is in their treatment is working, that their symptoms are going down? And we wanted to provide some definitions on that. So a treatment response is going to be a significant response, 30 to 50% reduction in the baseline of symptoms from pre to post treatment. We do know that there's going to be instances where residual symptoms might still be present, and that's not to say that the response hasn't been significant. Remission is when we talk about that there is improvement and there's no more symptoms. So we are no longer meeting diagnostic criteria for a diagnosis. And so this is something that we're looking at pretty intensely when we're conducting prolonged exposure with our adolescent populations here at the Skyland Trail Adolescent Campus. And so when we talk about these different areas of progress, one of the things we want to keep in mind is what kind of assessments we're using. And so assessment is going to be key in understanding what progress really looks like. And then recovery is an aspect of being able to maintain in that sustained remission stage. We do want to be able to acknowledge that sometimes someone might get worse, right? What does that look like? Relapse of certain behaviors. Are we starting to return to substance use, self-harm, maybe an increase in their experience of behaviors, maybe their nightmares or their hypervigilance has increased drastically. Maybe they're deteriorating in some form or fashion, whether that may be some with hygiene or their self-care. And then we're just seeing that persistence of clinically significant symptoms. And then also noting that there may be no response at all. There may be a minimal to no symptomatic improvement post-treatment. And that's not to say that this client doesn't have PTSD. Maybe this client wasn't as engaged. There could be a million different reasons, right? But it's important to understand that progress and how we measure that progress is going to be important, that we're using evidence-based assessments, one, but that we're also identifying that everyone's progress is going to look different and that we might have to go back to the drawing board and do some different treatment planning to be able to effectively meet each individual client's needs.
So effective treatments for PTSD exist. There are psychotherapies, there's cognitive processing therapy, CPT, prolonged exposure therapy, which is what we're talking about today, trauma-focused cognitive behavior therapy. And paroxetine and sertraline are medications that are FDA approved, but note they are approved for adults, not children. So, there is a big need for effective treatments. There are ones that work for most people. And while they do work for most people, approximately 33%, even if they do get an evidence-based treatment, don't recover. It doesn't mean they don't have any symptom change. They just don't meet those definitions. So there's a lot of work in the area to try to improve and augment our treatments. So what we're talking about today is prolonged exposure therapy. So these are the adult manual and the adult workbook, which I'll start with because that's what started, and then Caitlin will take you into the adolescent version. These are on the second edition. It's evidence-based therapy. These manuals are available to the public on Amazon, etc. If you are a VA provider, they're also available within VA at no cost in digital form. So PE is an evidence-based therapy for PTSD. It's a type of cognitive behavior therapy. It's been studied since the 1980s. When we talk about those guidelines, it's endorsed as a first-line treatment in every single guideline, including Institute of Medicine, the International Society for Traumatic Stress Studies, the VA in the United States, the DoD, and the NICE guidelines in the UK as example. It is a manualized protocol. There are those workbooks that I just showed. And it's been shown to be effective in adolescents as well, which Caitlin will talk a little bit more about in a little bit. And I think for the context of understanding where we're coming from is we participated in a training and certification program through Emory University. The veterans program there has grant funding to disseminate PE. And it's a 6-month program where each therapist has 2 cases over 6 months that they do complete. And each of those sessions are listened to by a consultant. And the therapist has to meet 80% fidelity in order to be certified. So it's an intensive process, but it makes sure that people not just get a training, but learn how to implement it effectively. So PE is 10 to 15 sessions in 90 minutes. There is a 60-minute protocol, but that's not what's in the workbook. I'm happy to talk about it if people have questions. And you use graded exposure to the feared stimuli. People, places, things, thoughts. You're working on all that with the patient and you're confronting those cues. And so that our brains can discriminate what is actually dangerous and what is more likely to be safe. This is extinction learning. So if we think about Pavlov's dogs, if you kept ringing the bell over and over and over again and no meat showed up, eventually they'd have new learning that, hey, the bell's no longer associated with meat, so I'm not going to salivate anymore. And that is what we're doing, again, reductionistically here. We are exposing people to the things that they fear that as therapists, right, we know that are unlikely to be harmful. And so that their brain can discriminate, hey, just because I'm smelling perfume doesn't mean I'm getting in a car crash anymore. Hey, just because there are items on the street on garbage day doesn't mean they're going to be roadside bombs like there were in Iraq or Afghanistan. So really being able to give our brain the tools to discriminate. Patients have practice in between sessions, so they're listening to imaginal recording. So when they do their imaginal exposure in session, it's recorded and they're listening to it multiple times in between sessions. And they're conducting practice exposures in between. These are called in vivo exposures. So these are things we can't really do in session, right? Going to Walmart, going to Target, talking about things that are uncomfortable with your parents, going back to the school that we know is objectively safe, but where something terrible happened. So really going through and using skills to be able to gain mastery in those exposures. Again, it's like extinction, fear extinction, right? We're repeatedly and gradually confronting memories, reminders, and situations associated with trauma. Part of the therapist's role in this is not to throw people into the deep end. It's not to say, hey, the scariest thing for you is, going to a football game at your high school because there aren't as many adults there and you don't know what's going to happen. If that's the scariest thing, eventually we'll get there, but that's not what we're going to start with. We're teaching patients that they can discriminate, their brains can discriminate between the trauma-induced fear and the neutrality of the stimuli, right? So teaching them, right, that the light is not dangerous. The light just happened to be there when the foot shock was there. And this lessens the fear response over time. It's not automatic, but think about, being in a situation where you're scared. You can only be there so long, right? Because you're using a lot of resources. Your brain's like, we gotta go, we gotta fight, we gotta flight. We gotta use a lot of resources. And then if that keeps going on, your brain's like, wait a minute, I'm using a lot of resources. I'm really tired. What's going on here, right? And it'll eventually dampen the response.
So Alex mentioned before, showed you the lovely pictures of the adult manuals. These are the adolescent PE manuals. You'll see there's a therapist guide, and then there's also a client workbook. These are really great tools and resources if this is a modality that you're offering to your clients. One, because it's developmentally appropriate. One of the things you'll see is that the verbiage is different, the examples are going to be different. They're going to be more understandable, and they're going to be things that kids may be able to connect with in a way that may help them have some of those outcomes that we want to see in terms of remission and symptom decrease. I don't know if you've ever worked with children. What do we know? They lose things. And so having a workbook, having something they can keep with them is a beautiful part of this process. I encourage you all to use those workbooks if you can. And you'll see that one of the biggest differences that our team notices is like even the clinical trauma assessment that you're using to identify prolonged exposure is going to be the route we take is a little bit different for adolescents and may not, it doesn't necessarily go into as much extent with like substance use. And that, with that being said, it's important to know that all of these resources, both the adult manuals and the adolescent manuals, can be used in the adolescent population. I think it's just going to depend on your client. It's going to depend on what's going to be most fitting for their needs, and being able to interchange using resources from both is really helpful, because we do see that some adolescents who are completing prolonged exposure do have a lot of challenges with substance use, and having those resources is going to be a great support for them as they're doing this work as well. So we just wanted to make sure and give you guys some of these resources to utilize and be able to understand the difference, and that these ones are just kind of geared towards being able to meet these kids where they are in a little bit of a different manner.
So if you've been sitting here and you're like, wait a minute, PE for adolescents, I've heard a lot about TFCBT. Yeah, you probably have. TFCBT, if you're familiar with it, is evidence-based treatment for PTSD in kids and adolescents. If you're familiar with it, you've probably heard of this practice mnemonic, right, with saying the different stages of treatment in TFCBT. And they're both excellent. They're both evidence-based. They both have good outcomes. They both are exposure-based treatments. And the person, Esther Deblinger, who developed TFCBT, started in the PE world with Edna Foa, who co-wrote the manual. So it is a natural and evolution of them. We are talking from the experience of our setting, and when we think about why PE works for our setting, it's a session-by-session protocol. So if you've done TF, it's not a session-by-session protocol, which can be beneficial in some cases. For our situation, it's nice to know this is 1, 2, 3, and this is how we can justify it to insurance companies and give parents and kids an idea of what to expect, and that there is a set end date to get through it. TFCBT is designed for caregiver involvement. So we're a residential facility primarily. We also have a partial hospitalization program. But there's, the kids are here, right? And there's not a lot of caregiver involvement. We're doing this during the workday. And so to have a protocol that can still effectively treat trauma or in PTSD that doesn't have as big of a caregiver component is really key to us. Our population is 14 plus. So definitely solidly in that adolescent window. So in that, it's a good candidate for the data that showed for PTSD for teens. There are a lot of skills given in TFCBT, which is really great. Our kids are in CBT or DBT as well, both individual and group. So they're getting a lot of these other skills elsewhere. So we have this time for them that's just treating their PTSD. When we think about why we don't do, when we wouldn't do PE, if there are maturity considerations, where, yes, they're 14, 15, 16, but they don't act or process like a 14, 15, 16-year-old, we'd refer to TFCBT. If psychological testing comes back indicating there are milestone developmental delays, again, we probably do TFCBT. It's also if it's the patient's preference, but it's not avoidance. So we always like to suss out, right? Is this avoidance or is it not? And if we feel strongly it's not avoidance, and the patient's like, hey, I'd rather do this thing when I leave here, that is their choice. And the data suggests across all psychotherapy, including PTSD, right? People do better when they get their treatment of choice if it's an evidence-based treatment.
Okay, so now I'm excited. We're going to get into some case studies, and we're going to focus a lot on some of the applications of prolonged exposure in the adolescent population. Again, like Alex said, this is based on our own learning on implementing PE in our residential and our day program here at Skyland Trail. So we wanted to start off with a little bit of a case study that I'll reference throughout some of the slides moving forward as well. And then I'll introduce some other cases along the way, just to kind of provide some context of what we're talking about, what we're seeing, and all of those things. So Chrissy is a client that's a 15-year-old non-binary individual, assigned female at birth, comes from a family that's pretty, what we would say, traditional, married parents, lives with their grandmother and an older sibling. No major family systems challenges that this client presented to treatment with. Chrissy had attended outpatient services before. This was their first residential treatment that when they came to us here at Skyland. And when they came to us, they had a diagnosis of depression and anxiety, and there was no known or reported trauma prior to coming to us. So one of the things we do here with all of our kiddos is they get a wonderful slew of assessments, so we can kind of understand and pick apart what's really going on with them, in addition to their self-report, team report, all of that. But Chrissy at admission scored a 39 on their PCL-5 assessment, which is the trauma assessment that we use here in-house, as it is validated to use with adolescents. And it is important to note that a score of 33 or higher is validated in adults. The probable PTSD when criterion A is assessed. So in the next slide. So when Chrissy came to us, again, there was no known history of trauma. However, just 16 days after being here with us, she did disclose that she had a history of trauma within her individual sessions. And this was partly, this contributes to a number of different reasons, but she developed a really great rapport with her therapist. And she did report that she had developed multiple sexual assaults at a summer camp that she was going to as a child. So again, as she, only a few years before she had come to treatment. So with that being said, Chrissy was able to open up and share about this, this trauma that she experienced. And it's important for us to also look at what are the different symptoms that she presented with. Again, anxiety makes sense, as she came to us with a diagnosis of anxiety. She had a lot of mood lability. So she would be really, really down. She would then be really, really intense, really angry. She would be really sassy. She had a lot of mistrust of adults. She really did not like being around men. One of the things that was really notable for someone like Chrissy was her hygiene decreased significantly. She would not shower. She did not like to take care of herself. And she also modified her clothes significantly. She was a small person and she would wear the most excessively baggy clothes because she didn't want anyone to see her. She didn't want to be seen. All of these, again, barriers she was putting in place to protect herself. A lot of hypervigilance, quick startle response. She isolated a lot, resistance to discussing her trauma. So you can imagine working with a 15-year-old who never disclosed her trauma before, how that was a challenge for the team. But in addition to that, she experienced a lot of suicidality and self-harm, which is what brought her to us, excuse me. And then we also saw different areas where things were being impacted, like her social relationships, her school. Again, we have a 15-year-old who is working on developing their sense of self. And this extensive trauma that they had experienced was this plague that was impacting every area of their life. And we're really glad that Chrissy was able to come to us. So I'm going to be referencing Chrissy throughout our throughout the remaining of time. But one of the things we want to touch base on is the next slide. So starting with some of these considerations of working with adolescent patients, family involvement and support is going to be one of those areas that is really crucial in supporting a young person who is engaged in prolonged exposure therapy. So how do we do that? How do we want to make sure that a family is involved? And what are some of the things we want to think about as we are thinking about how a family might or might not be able to provide support to a young person? So the first thing that's really important is not only do we want to spend a significant amount of time educating our clients, our adolescent clients, if they are going to be a candidate for this treatment. We want to educate their families. So it's important to provide them an education, kind of what we're doing today, to families, caregivers, support networks of those who will be living with, taking care of these young people, whether it's in residential or on a day treatment or outpatient setting. So there's a lot of wonderful resources out there that you can provide to families, like Q&As to help them understand what this treatment is for, why this treatment might be helpful, why we're recommending this treatment versus others based on, hey, well, they've had anxiety for years, why are we just now focusing on trauma? Again, based on our assessment and based on our rapport building within the team, we're able to get a better picture of understanding the role in which trauma is actually playing in these young people's lives to really target that. And then as we talk more in a moment about comorbidity, it helps to understand just some of the different pieces and how they do fit together. As we're working with minors, informed consent is going to be really important, not only for our children, do they understand what they're signing themselves up for? We want the families to understand and have a picture of what their child will be experiencing as well. Part of prolonged exposure is there is recording involved, and that could be done in a audio recording or a video recording. And as a part of that, we want to make sure that the parents and the child know what happens with those recordings, who has access to these recordings, and making sure that everyone feels comfortable with the confidentiality and the safety measures that we're putting in place to protect their sessions. In addition, we want to make sure that we know that we don't always work with families that, with parents or caregivers who are on the same page. We don't always work with caregivers or parents who may want to be super involved for a number of different reasons. Some of the parents or caregivers may also be the perpetrator of the target trauma that may be focused on within a PE, within PE sessions. And for that reason, you may get some varying parent approval. And that's something that's one of those bridges you cross when you get to it. Do we go back to the education? Do we go back to the clinical assessment and really informing why this is our recommendation and what our anticipated goal is in doing so? And then again, we want to talk about the limits of engagement. One of the things we've seen pretty frequently here in working with our children is that parents want to know any and everything, which is a great thing, right? We want our parents to be involved. We want our parents to be present. However, we also have to maintain that our clients have some level of autonomy and that we do have to maintain their confidentiality to a certain degree. With that being said, when there are sensitive topics, whether it's sexual abuse, physical abuse, when we have to do mandated reporting, that is something that we're going to talk about with the child. That is something we're going to give them a heads up on, because we do know that, like Chrissy, who was mentioned before, this was something that had to be reported because it had never been reported before to any adults, let alone to Child Protective Services. And knowing that she experienced a trauma in a communal environment of sorts at a summer camp, we needed to make sure that other children were being protected too by reporting that. So with all that being said, it's important that if you are conducting prolonged exposure or any sort of trauma treatment with adolescents, minors, that you are familiar and trained on the reporting process in your state and how to follow through if you are working with clients in other states as well. And it's important to establish a process. How are we informing the client and how are we informing families if a report needs to be made? As we know, mandated reporters, it can be done anonymously. When we work in a residential setting where we know families know we're starting trauma-based treatment, it can get a little messy if we just leave it up to chance that, CPS is going to be the one to notify them that a CPS report is made. So what we like to do is we like to make sure we're informing the client. And then do we talk about some goal development, some in vivo exposure opportunities by having the child work towards telling their parents what and if they feel comfortable telling them. So again, family involvement is huge. Mandated reporting is something that is a necessary component of this as well, because we want to make sure that we're protecting these children and we're doing our due diligence as ethical providers as well. So with that being said, I'm going to reference Chrissy's case study quite a bit here. Chrissy's case was, again, it was a challenging case to say the least, but it was a very successful case. We got Chrissy's family very involved. Once they found out about the trauma, they were highly involved throughout the process. And so what did we talk to them about? We let them know about the necessity of the reporting sessions. We provided them with informed consent on participating in this process. And one of the things that Chrissy's parents did that was really, really cool was they were able to support the implementation of homework for Chrissy when she transitioned from our residential program to our partial hospitalization day program. So they were kind of her accountability buddies, which was wonderful. And again, goes back to the importance of having that parent family involvement, because you can help hold these young people accountable when they've learned. What have they learned? Alex has told us avoidance is key. They've learned how to avoid in so many different areas, and sometimes they need that extra support, right? So Chrissy's parents were extremely on board. They were able to provide treatment updates to the team. They were able to work with the team to plan in vivo exposures to identify these new items on her hierarchy. That, because again, residential treatment is a wonderful place, but it's a bubble. These kids come here and they're basically in a safe little place. Now, we all know shenanigans happen with a bunch of teenagers in a treatment program, but for the most part, they're not dealing with the same day-to-day struggles that they are. So when she transitioned, her parents were able to help add additional items to her hierarchy when they noticed that new challenges were arising. And again, they helped to hold her accountable with following through on her imaginal exposure listening sessions. And they were able to start identifying some of her different safety behaviors. So it was really interesting. One of her in vivos was to take a shower with the door closed, without locking it. And she was finding all sort of ways to implement safety behavior. So she didn't like to shower. She didn't like to be nude because of her trauma. And she was finding ways, well, I didn't lock the bathroom door, but I did open every single drawer so that no one could open the door to get in. So it would make me feel safe. So being able to have Chrissy's parents involved helped to provide an extra layer of understanding how she was implementing safety behaviors when she may not have even realized that that was what was going on there. So we're going to talk a little bit more as we go through slides about in vivos and what that means, but just to give you a few examples, Chrissy's parents specifically took her on hikes and camping trips. Again, her trauma was based on going to summer camp, and so she was having to stay in the woods and having to be in that environment again, exposing herself to what is an objectively safe experience. She had supervised imaginal listening sessions, and her parents had a child sex talk. This is something that, again, personal experience is going to be important here. If you've ever had a conversation with a child or an adolescent about the sex talk, it's not comfortable for anyone involved, typically. However, when we talk about this as an in vivo opportunity with someone who has had some sort of sexual trauma, it is a great opportunity as we talk about developing this new perspective, identity around sex, a comfortability with sex that may have been taken away as a result of that trauma. And then they went to malls and they went to restaurants because, again, this young person was completely isolating out of life. She was not engaged in life in any way, shape, or form. And so part of her in vivo was, how do we help her get the life back that she wants as a 15-year-old young person? And so again, Chrissy's parents extremely involved. They learned her SUD scale, and they were able to identify those safety behaviors, like I mentioned, when those came up. And safety behaviors are those things that clients may implement as a result of managing their distress, right? So we're not avoiding the situation, but I'm going to do something that's going to make me feel better, right? So as I mentioned, she would take showers with the door closed. It wasn't locked, but she would open every single drawer so the door couldn't be opened. That's a safety behavior, right? So do I go into the store? Okay, you told me to go into the store, but I'm bringing my hydroxyzine with me just in case I need it, right? So what are some of these things that people are doing to keep themselves safe, even though they're not avoiding? So family engagement is a huge consideration. Another consideration is medication management. We want to be able to be mindful of the fact that a lot of our clients are working on treatment teams with different providers, and one of those providers may be providing them with medication management. And that's not to say that medication involvement or working with a client who may be going through medication changes is not a candidate for participating in PE. I do think this provides an opportunity to work on an interdisciplinary team and to be able to be in contact with your client's providers as they are going through the prolonged exposure process. So again, changes in medication are not necessarily an indicator to stop prolonged exposure. And again, it's important to talk with these clients about what are they experiencing? How are they noticing changes within themselves physically or mentally as their medications are changing? And how does that relate to some of their goals and some of their targeted behaviors that they're focusing on within the prolonged exposure process. So I think that, a lot of times medication is a huge asset to an individual's success as well. And we don't want people to be afraid that someone who is being treated for medication or going through medication changes may not be a good candidate because we may not be able to capture what's really going on. However, that's not the case. So as I mentioned, working on an interdisciplinary team is an absolute huge benefit. It's something that here in a residential setting, we are very fortunate to have access to. We do understand that not everyone has the same opportunity or the same setup to work on an interdisciplinary team. However, we wanted to spend some time of how do we encourage you all to be mindful of the way in which we educate our teams, in which we work with other providers to be able to effectively implement prolonged exposure. So something we want to touch base on is just really how are we talking about prolonged exposure? How are we educating our staff on what's going on and the process that they're going through? How do you have some team conceptualization meetings? Something we do here weekly is we have a PE conceptualization meeting where we create a space for collaboration. And that's really what it is. Hey, I need help creating this in vivo opportunity, this in vivo exposure for a young person. How have you done this in the past? It may also be just addressing challenges of over-engagement or under-engagement when a client is participating in PE. And then keeping each other informed. I think that it's important to, as we're working with different providers, whether that be residential staff, whether that be the doctors, whether that be education, that everyone's on the same page of like, hey, what's going on? Now, we want to be mindful of protecting confidentiality and boundaries, right? We are not going to necessarily notify everyone on the team why someone is doing prolonged exposure or what they're working on. However, we do want to give them a heads up in this communal environment if someone is going to have a difficult time, or if they're working on something that may be a little extra challenging for that day or for that week. And we want to create a debrief process for the team as needed. Again, we don't want to impact staff negatively in the process of them supporting our kids. And we're very fortunate here to work in an environment where staff will volunteer sometimes to participate in vivo exposure opportunities. If you ever need to hire an actor, Alex Rothbaum is your guy. He is wonderful at engaging in some role play type scenarios where we're able to, whether it's arguments or whatnot. So with that being said, though, sometimes staff members who participate in these processes need to just be checked in on, make sure that they're also okay as they know what's going on in the process of maybe participating in an in vivo exposure opportunity. We all know that people are well-meaning, and we know that people have the best intentions, especially when we work in the helping field. However, we also need to be mindful with that in mind that there is the potential for avoidance collusion. And we want to make sure that when people are working with children, we can sometimes want to rescue them. We want to sometimes make them feel safe. And yes, we want that too. And in the spirit of prolonged exposure, that could potentially be a barrier to success if someone is colluding with avoidance in any form or fashion when exposures are happening. We don't want to fragilize the clients. We don't want to teach them that they can't do things, because if we tell them, hey, yeah, this is really hard, you shouldn't have to do this, what you're teaching them is, yeah, I know I can't do this and I don't want to be a part of this, which is then going to interrupt their treatment process. So we want to make sure we're not going rogue with exposure. Again, people mean well, but we don't want to start implementing exposures left and right because that may be counterproductive. We want to offer exposure opportunities in ways that are contained, in ways that are structured, and the ways that we are measuring them to be really understand what was gained from that experience and how we can build on that within the hierarchy of prolonged exposure. And then we want to be intentional. We're going to talk a little bit more about this intentionally as we move forward, but we want to make sure that we're keeping modalities separate to target different goals. All right, so this is a whole slide about how to not collude with avoidance. We want to make sure that if you take nothing else from this, that we understand that prolonged exposure, we are working to confront avoidance. And Alex is going to talk about a study in a minute, but one of the things that's important for us as clinicians is to be aware of our own avoidance and how that may show up as a barrier to success that these individuals are going through within the PE process. Meet your clients where they are. Yes, when we start a new process in any form or fashion with children, we want to make sure that we kind of build onto it. Scaffold exposure, give them opportunities to build up that into the hierarchy and do harder exposures. If we throw them right into the deep end, that may be off-putting and they may not be more likely to participate. Educating staff, again, I've mentioned that. The statement of what are you guys doing with these clients, right? So again, if people don't know what's going on, if they don't have the basic understanding of prolonged exposure, they may have some questions about the efficacy, the ethicalness, whatever that is. but exposure-based treatment is very effective and is a very ethical approach to working with clients with PTSD. Make modifications. I'll talk a little bit about this more in a minute, but basically, again, how are we meeting these teenagers where they are? What are we doing to identify whatever it is in our power to make them be successful as they work through this treatment? So imaginal exposure listening sessions. So as Alex mentioned, there's two types of exposures that we're doing within prolonged exposure. The first is an imaginal exposure where the client is talking about their target trauma memory, and then they have provided opportunities to listen to this recording or watch the video of themselves telling this story. So one of the things that we have learned through trial and error is what can we do to encourage as much success as possible when we're facilitating an imaginal exposure listening session. So again, confront any and all avoidance. What are we doing to ensure that this client is sitting, they're following the directions, they're listening to this session, and that they're getting everything they can out of this? Utilizing your team effectively, how do you ensure that people aren't being burnt out or pulled in too many different ways to support this process of having this emotional exposure listening session in the day treatment? So this is where, again, your residential day treatment outpatient services, it may differ in what this looks like, because you may have clients do this independently at home versus in our residential setting, they're doing them throughout the day and throughout the days of the week. Identify safety behaviors. When we're getting creative, again, this is an area where we can build on that creativity. We have clients who like to fall asleep, who need to go to the bathroom, who need water, who are speeding up their listening sessions, and that's where technology can get in our way sometimes. So again, what are our clients doing to protect themselves and make themselves feel more comfortable within those listening sessions, and how do we address that in their process related to their goals? Involve the client. Hey, how is this going for you? What are you seeing this cause a barrier in your treatment by engaging in this safety behavior? And get creative. I love to work with teenagers for a number of different reasons, but part of that is because they are very creative and they teach me things all the time. And when I am conducting in vivo exposures as well as imaginal listening exposures, they can be a huge resource for you as you get creative within this process. All right, what's next? So next up, we're going to touch base on the in vivo exposure development. This is one of the most interesting components, in my opinion, about doing prolonged exposure. It gives you the opportunity to be extremely creative. I do want to be mindful of time, so I'm not going to go through every single example here, but when creating in vivo exposure opportunities, it's important to really encourage the client to be a part of this. I provided a list of some examples down below. And one thing that's really important is to know that sometimes it may feel a little controversial what you're doing. It may feel a little uncomfortable to people. And again, we're never going to expose a client to something that is actually unsafe. We are encouraging in vivo opportunity exposures for things that are objectively safe, that these clients are avoiding, that are then impacting their life. So things like we've had law enforcement come to our campus before, which has been a really cool experience for a young lady who dealt with a lot of domestic violence in the home, leading to law enforcement being brought in several times in her home. Utilizing video, music, movies, food, gum, scents, all of the senses that you can bring in are going to be a really important part of this process. Conversations with peers, observing fights, doing some role plays, a really cool part of this. But again, providing incentives and encouraging their motivation to be successful in this is going to be super, super important part of this. Don't be afraid of feelings. Sometimes kids are going to have meltdowns. Sometimes there's going to be some really uncomfortable situations that they're going through, and that's because they're dealing with those feelings. Again, we're not subjecting them to unsafe situations. They're just now having to confront a lot of areas that they're avoiding, which is a big part of this process, right? Knowing your client is super important, and how can we overcome barriers to help them succeed? Again, one of the things we'll touch base on related to a case study is reassurance of client safety. We always want to be mindful of safety. If safety concerns arise, like self-harm or suicidality, we always want to make sure we're assessing that first and foremost before continuing on in the prolonged exposure process, and the role that any avoidance is playing within those same behaviors. So this is the hierarchy from Chrissy, to give you an idea of kind of what she identified were her biggest areas of avoidance. So in this The second column there where it says session 2, it breaks down different areas that she recognized were the biggest areas of avoidance that were impacting her life. And the SUDs, her subjective units of distress, are labeled there for, again, this was at the beginning of her treatment. And that final column there is her final session, where you can see that every single exposure opportunity she had did decrease significantly. So a couple of the examples were having the sex talk that we already mentioned, spending 40 minutes in a loud, crowded public space, having a confrontational conversation, spending 30 minutes in a small dark room alone, sleeping in a bedroom with no lights on, introducing yourself to a man you don't know. And so these are examples of in vivo exposures that we would carry out with this client. And what we would do is help them set that up and figure out, they would track their SUDs within the exposure opportunity. And then we would keep track of those things throughout their treatment and see at the beginning versus the end, how have you grown? How have you decreased your fear and your distress related to these situations based on these subjective units of distress? So this was a really cool example of someone who was successful in their hierarchy. Additional considerations, make sure that you're identifying what the target area of improvement is. What is the treatment goal, and what are we doing to ensure that we are really focusing on that target goal? And are we wanting to make sure that we have a specific outcome of clinical response versus clinical remission? So again, what are we working on, and is everyone on the same page in the treatment team? And are we on the same page with our client? We always want to make sure that our clients are motivated and committed to the treatment. PE is hard, and we want to make sure that they have a good buy-in and participating in this treatment. With that same aspect, this is voluntary. We never want to coerce or force a client to participate in treatment. As we know, no one's ever going to be ready to complete trauma treatment. However, we do want to give them that autonomy to be able to say they want to drop out, should that be the case. And then again, we don't want to start a treatment if we don't have enough time. Prolonged exposure, as Alex mentioned, is 10 to 15 sessions. We are very mindful of that in our residential setting when we think about starting prolonged exposure and whether or not we have the amount of weeks we need to effectively complete a full round of prolonged exposure. When we talk about comorbidity, Alex did talk a little bit about this before, but again, we don't want to look at substance use or comorbidity as a barrier to utilizing prolonged exposure. It can help us to understand a client's experience. It can also help us to understand just their general avoidance in life, different areas of functionality that may be impacted as a result of these things. I will say specifically for the substance use that what I see in the clients that we work with is that substance use has been used as a maladaptive coping mechanism or avoidance 101 in dealing with trauma-related symptoms. So again, it's important to look at the modalities that we can implement concurrently and the ways we can address these different areas at the same time. However, that's not a deterrent for continuing prolonged exposure treatment.
Awesome. And so, as we've mentioned, assessments can help. They can help you differentiate diagnosis. They can help you develop targets. They can assess functional impairment. It's a key part to any evidence-based practice to give assessments, including PE, and it's built into the manual. There's a lot of thoughts we get of, I have to treat whatever else, the substance use, the suicidality, whatever, before I get them ready for PTSD treatment. This is a myth. No one has to be ready for PTSD treatment. The only time that they do is if they need, if they're acutely homicidal or suicidal to where they need involuntary treatment. And even then, there have been studies that if they're in involuntary treatment, you can treat PTSD, but you want to make sure they're safe first. But then if they need medical detox, they've done PE with psychosis, they've done PE with comorbid substance use. This is the COPE protocol, which is a mixture between CBT for SUD and PE. It's published for adults. There's also a study that they've published the preliminary protocol of doing it in adolescents. So treating the substance use and treating PTSD with PE at the same time.
All right, so touching briefly on addressing comorbidity, one of the things we do here in our program is we offer CBT and DBT as our core tracks, and then we offer PE in addition to that. So it's important to be able to balance concurrent implementation of different therapeutic modalities because it can feel really overwhelming. However, it is doable. So when we look at conducting DBT and PE at the same time, we're looking at individuals who do have some of these comorbid diagnoses, who do meet the criteria for PTSD, but are also experiencing ongoing challenges related to suicidality, self-harm, interpersonal challenges, emotional dysregulation, all of those key indicators that DBT may be a positive impact on this young person. But we also need to be mindful that PE and DBT may be teaching these kids some different things. While we look for in PE, we want to help these people deal with their hard feelings, sit with those just uncomfortable feelings, manage hard emotions. DBT is really teaching them to contain it. And so one of the things we want to do is how are we teaching them to maintain both of these things at the same time? It's a great opportunity to mirror dialectics. However, we want to make sure that they are provided space for doing their PE work, but then also doing their DBT work separately. We want to make sure that we are addressing safety assessment, that we're doing great safety planning, because again, if we have young people who are good candidates for DBT, they may have a history of self-harm behaviors that we should take into consideration as we're doing safety planning, as we're addressing avoidance. Are we looking at willful behaviors, or is this more of the avoidance we're talking about? And some of the things we've done here on our campus specifically that's been really helpful is providing different clinical clinicians to conduct those different modalities. So someone will be their PE therapist and someone else will be their DBT therapist, giving that client space to address both of these different areas. And then also a great opportunity to bring the team together to really focus on how those things are commingling together and how that relates to their bigger treatment goals. One thing we wanted to make sure and touch on was maturity. So as we know, children are immature, children can be silly, children can be full of nonsense. I always say they're full of shenanigans. Well, that's not necessarily a bad thing. We want to make sure that we are allowing kids to be kids. We're allowing age-appropriate behaviors where they belong, right? We can use rapport and we can use good conversations with our clients as a way to balance the art and science of conducting prolonged exposure or any trauma-based treatment. However, we do want to make sure that we're not pathologizing age-appropriate behaviors. And we want to make sure that with that being said, how are we grounding the patient back to their goals and ensuring that some of that silliness, some of those shenanigans I'm referring to aren't getting in the way of what we've set out to do within prolonged exposure, or that their silliness or nonsense is turning into avoidance as well. But I say that as a hopefully a PSA, an encourager of like, don't allow that to be a deterrent when we talk about assessing the productivity or the outcomes of prolonged exposure. PE can be fun. I know that sounds really wild and really crazy. Some of the best sessions, some of the best clients I've had, we've been able to have moments of laughter and joy within these sessions, because again, as their symptoms are reducing, their PTSD is going into remission, they're able to be brighter, they're able to be more themselves. And it's a really cool moment to be able to have a laugh and enjoy a positive moment in this really dark and hard process with clients who are getting the help that they need.
All right, so we're gonna blow through some of this of talking about therapist avoidance and some of our other case studies. We're happy to talk about them in questions. We want to be mindful of your time and thinking about trauma treatment myths and kind of ending on that note. So there are a lot of myths that are prevalent about trauma treatment. They harm patients. People are well-meaning, but we want to make sure that patients get good treatment. So they include thinking about the trauma as bad. It's not bad to think about the trauma. Exposure isn't re-traumatizing. It's helpful if we do it in a way that is therapeutic and along the lines of these validated treatments. People don't have to be ready for trauma treatment. There are, again, a few situations where you want to make sure they're safe, but readiness is a myth in a lot of therapist avoidance. And you don't need therapy before you start trauma-focused work. You can jump right into it, and a lot of other things get better when you treat the trauma. If they have an uptick in symptoms, that's normal. The analogy I use is we're going into the box attic, we're dusting off some boxes, we're opening them off, and we might get a little sneezy because we are allergic to dust, but we're still going through the boxes. And if they are multiply traumatized, PE will still work, and there's plenty of evidence to suggest that. So to wrap up, PE is appropriate and feasible in adolescents with comorbidity and a lot of impairment. Good assessment is really key. Clinicians need to be mindful of their own avoidance and their role in the patients of avoidance. It's important to align with the patient's goals as you balance the art and science of therapy. Psychoeducation is important for all of those involved. And then even though parents are part of treatment, making sure they feel informed, aren't part of this treatment, making sure they feel informed enough is important. Comorbidities may feel like a barrier, but we can do concurrent treatment and there are ways to do that. Be creative, have fun, like Caitlin said. It can be really fun to think about these things as a team. Don't be afraid to pull from both adult and adolescent literature. Encourage, respect, and support patient autonomy and choice. Therapists don't have to be experts in the underlying theories to deliver good PE. That's the benefit of manualized treatment. And most people don't have easy access to evidence-based treatments for PTSD. So be mindful of all the misinformation circulating in patient and therapist circles. Thank you so much for being with us. Molly, I think maybe we have time for 1 or 2 questions, but you're the MC here.
We do. Thank you. For some reason, there's my video. Okay, for some reason, my video isn't working. Thank you, Caitlin and Dr. Rothbaum. As a reminder, you'll receive your personalized link to your attendee dashboard where you can complete the evaluation form and download your certificate immediately for CEs. If people have to jump off right now, if you have any questions, put them in the chat. We'll hang around for a couple minutes. Some questions have come in. So the first question is, what if a person has multiple traumas that can meet criteria for PTSD?
Yeah, so that's where good assessment comes in. And Caitlin can talk about this too if she wants, but her team regularly does multiple PCLs. So you figure out what the different traumas are. You ask them what haunts them the most, what impacts them the most, and you try to parse it apart to kind of get at which is the one that does kind of haunt them the most, leave the most impairment. And in most cases, we see, and the data supports this, that the skills learned with treating one trauma with PE generalize to the other traumas that are causing PTSD, and you don't need to go through another trauma. Molly, you're muted.
I got it. Thanks. Do you begin PE therapy even if clients have symptoms of dissociation, or are there precautions before starting treatment?
So that's not something we've seen a ton here on the adolescent campus. However, I do think that being mindful of dissociation is important. However, should not be a deterrent from being able to participate in prolonged exposure. Again, as we look at addressing the target memory and being able to carry out the protocol, it's not a deterrent from what I've experienced thus far. Alex, I don't know if you want to add more to that in terms of your own research on it.
Yeah, and when I've had patients who dissociate, that's fine. That's one of their avoidance tactics for coping. So we figure out what it looks like. We develop coping strategies. I know I had a patient who, whenever she started dissociating during Maginal, we figured out that if she started singing the lyrics to a certain song, that would ground her enough to keep going with the Imaginal. So there are different ways to ground people, and dissociation is not a deterrent from doing PE.
Great, thank you both. And we'll do one more question. Can you do PE in a group?
So PE is a direct intervention, is not designed for group therapy. There is a separate manual called the IOP manual, the Intensive Outpatient Manual, by many of the same authors, but in the same serious treatment that work. It includes group activities, and that is like a group in vivo exposure. For example, the imaginal exposure has to be done individually, but there is the IOP manual for having as much group-based as possible in an intensive treatment.
Now, if you're doing PE with adolescents, sometimes they do think it's a group treatment modality, and you have to work on setting boundaries and appropriate exploration and talking about their experiences. However, yeah, we just do individual sessions here at the Skyland Trail campus, which we see it to be a really cool outcome though.
Great, thank you all. And I want to be mindful of the time. So again, you'll receive a link for the evaluations. If you have any other questions that we can help you with, please reach out to our team at Skyland Trail. Thank you all for being here today. I'm going to pass that over to Julie to close us out.
Yes, thank you everyone again for taking time out of your busy schedules, and Dr. Rothbaum and Caitlin, not Molly. Molly didn't do the presentation, but you did a good job too. Caitlin, thank you so much for the very informative presentation. It was great hearing more about PE and how we use it at Skyland, and wanted to also invite everybody to join us for some future events. We have a couple of virtual meet and greets with the adolescent team coming up. Those are on September 24th and October 4th. And we also have adolescent and adult campus tours coming up on September 30th. Thanks so much. And you can find additional information on our website at skylandtrail.org.